Thank you, Nima. Thank you for the introduction. Thank you, all the panelists, and thank you, APO, for this uh, webinar. I'll spend not more than 20 minutes on what is our experience in achieving health and equitable outcome. Um, it is level and distribution of health, as well as many other indicators. So these are the three topics. We have achieved USC in 2002 when we were lower middle income country with a GDP $1,980 per capita. And at the bottom of economic downturn after 1997 financial crisis throughout Asia. So if you look at the bottom of the curve, just at the benchmark of bringing to be a low income status. So that means at that time, the economic situation is not that favorable to achieve USC, but quite interestingly, we achieved that. John Gruber has said in his paper in 2019, saying that USC in Thailand certificate scheme is a great equalizer, meaning the under 5 debt gaps between rich and poor provinces become zero. This is a good name of the Thai UC. Equalize health outcome across rich and poor as a result of equitable access to care by everyone. These are some remarkable outcomes. Life expectancy at birth increased from 70.6 in 2000 to 77.2 in 2019. I'm also declined from 19 to 7 per 1,000 live births. Under 5 death declined 22 to 9, and MMR from 43 to 37 per 100,000 live births. All these key population health outcomes are higher than average of EAP, excluding high income country as well as upper middle income country for which we belong to. Also, evidence has shown that there is a pro-poor benefit incidence of the UC scheme. That means there is a higher use by the poorest quintile at primary health care. And also, high use without services is not possible. So that means there's adequate funding to primary health care because NHSO contacts primary health care network, not a standalone district hospital, but a network of primary health care, which we define as a sub-district health center and district hospital. Also, comprehensive benefit package with almost zero co-payment result in low OP, low catastrophic prevalence. And UNC is predominantly financed by general tax. And except social health insurance, which is payroll tax finance, we found that direct tax is the most progressive source of finance and much more than social health insurance contribution. Evidence also show financial incident is very progressive, and we have a slight positive Kakwani index. So that means the concentration index of financial contribution is higher than Gini index. So that means there's an income redistribution through UC scheme. So that means the rich finance health services more than the poor. This is a publication by the Virtual South Asia region in terms of figure on 2021, divided into 4 quadrants. X-axis is USC Service Coverage Index, which is 14 sub-indicators, 381 SDG indicators. And on the Y-axis is the prevalence of catastrophic spending. That means OP is more than 10% threshold. This is SDG indicator 3.8.2. And the dot red line is global average of USC coverage index of 68 and catastrophic preference of 13.5. Thailand was classified in the scattered plots among 11 member states of the WHO Southeast Asia as the best performing country in terms of low catastrophic and very high SC service coverage index SCI in quadrant 1. These are the life expectancy at birth and under 5. Thailand outperformed in these two indicators compared to EAP. Of course, exclude Japan, Singapore, Australia, New Zealand, high-income country in East Asia Pacific, and UMIC. Look at this indicator is quite favorable. Under 5 is at the bottom line, and life expectancy at birth at the top line. In 2019, Thailand current health expenditure per capita and also as percent of GDP is low relative to upper middle income country groups. For example, we spend $296 per capita or less than 4% GDP, while EAP spent $414, UMI spent $555 per capita. And if we measure by as percent GDP, it's much higher. So Thailand is outperformed in terms of lower costs with high health outcome. So that means some tacit intrinsic capacity in the health system. I would define as a health system endowment that we'll talk later. After USC was achieved in 2001, 2002, the yellow part, which is OOP, out-of-pocket payment by household, has reduced gradually from 34% in 2000 to merely 9% of CHE, much lower than comparator country. This is because the comprehensive benefit package and almost zero copay in the UC scheme, which cover 75% of Thai population. Also, GGHE, General Government Health Expenditure Domestic, as percent of current health spending also increased. You have to note that on the black portion of the graph, other source of spending also increased, mostly the middle income household spending on private health insurance. GGHE in 2019 as percent of GGE was something 15%. If you look at Thailand, GGHE as percent GGE in this here is higher. So that means government has commitment, not verbally, but financial commitment as well. OOP decreased from 30, as I said, 34% in 2000 to 9% in 2019. This is the predominant public finance USC, both government employee scheme, social health insurance contribution, and UC scheme. Unmet need, we compare ourselves with OECD average. OECD average, 26 member states of OECD. In 2021, the average of medical care need was around 2%. We replicate the work of OECD since 2011 by introducing unmet need model in the health and welfare survey conducted every 2 years by National Statistic Office. And every 2 years, we can produce unmet healthcare needs. This is more or less on par with OECD average and much better than other OECD, which is, for example, Estonia, Greece, Slovenia, whereby the unmet need is much higher at 8%, 6%. And also the gaps between rich and poor, lowest quintile and richest quintile. Then what explain this achievement? I have published a book chapter in IMF 2012, which is evidence-based financing reform, and found that it is still very valid. Health system capacity and resilience matters. There are at least three parallel synchronized reforms. First, primary healthcare extension since 1997 until full coverage of district hospitals in all 600 districts and sub-district health center in all 8,000 sub-districts nationwide. This full geographical coverage is the foundation of the implementing USC with adequate service, availability, and utilization. Second strand is health workforce development. Thailand has applied well before guidelines by the WHO on retention strategies. We introduced comprehensive multiple strategy applied since 1970s. Expansion of training capacity. We cannot rely on university training capacity. So MOH start to have its own nursing college. And we have published quite good number of papers on health workforce policy. The policy application is rural recruitment and hometown placement. You come from this hometown, you speak this dialect, you go back to your hometown. So they have longer retention. 3-year mandatory rural services for MD, DDS, B, Bachelor of Nurse, and B Farm since 72. And also exposure medical nursing student to primary healthcare at the clinical year and introducing interprofessional education and also introduce significant financial incentive and non-financial measures. So these are the blend of interventions. Finally, on financial risk protection extension, it's a long march since 1975 that we start with targeting the poor and introduce informal insurance, voluntary health insurance for the informal group, formal sector, government employee, and social insurance in 1990, and achieve universality in 2002. Of course, we have competent and well-trained workforce should be under two. So in this slide, I'd like to conclude that USC and PSC are the cornerstone of effective response to COVID pandemic, and we have published quite a number of papers to prove that and advocate USC and PSC. Second is governance matters. There is a participatory and responsive governance of UC scheme. Although we have quite uneven social insurance and CSMBS, which is managed by Finance Ministry, there's no participatory governance mechanisms. We have multi-stakeholder, including NGO, 5 NGO in the 30 members of the governing board of the UC scheme chaired by Minister of Health. We have 8 ex-officio. We have 7 experts. I'm one of them. I'm sitting one of the 7 seats there. We have 4 local government representatives, 5 NGO, and 4 professional council, and 1 private hospital association. From the political economy that I observed during the last 1.5 years, 2 or 5 years, the health professionals in the professional councils and permanent rep from permanent secretary of the government ministries, they protect the benefit of healthcare providers. And private hospital associate, of course, their position is to protect the benefit of private contracting providers. Therefore, the active members are the expert from relevant field, the NGO 7 + 5, which is 12, very much, but they are the minority because 30, half of them is 15. So these are only 12 that many policy to safeguard the benefit of the UC member is mostly advocated by experts from relevant field and also NGO. Financing design matters. We introduce purchaser provider split. Actually, CSMBS and SHI has its own purchaser organization, and NHSO is the last major purchaser for 47 million population. The supply side budget allocation was totally curtailed. So that means services budget is and funding rely on the demand side financing. There was a strong resistance from the MOH since then, since 2002 until yesterday, and it will continue next many years, because before MOH hold the budget power, now NHSO take over this financing power. Strategic purchasing and will result in improved efficiency and content cost. We introduce cost and budget. We have major capitation for OP. Majority of spending is capitation or for OP and DRG under global budget for IP. And contracting primary care and which enable access to all specialties, especially in Q1. Except for service for CSMBS outpatient services with significant cost increase. I have one slide on that. Comprehensive benefit package with almost zero copay, reduce OP and improve financial risk protection. And finally, new benefit package subject to full HTA, which ensure efficiency of resource use along with health system capacity to deliver services effectively. Next slide, please. Institutional capacity to generate evidence and inform policy are very much important. We have IHPP, high cap, to name a few, has fully institutionalized and continue inform policy. Reform champion, especially policy entrepreneur who link evidence and policy decision play a critical role. Of course, we need policy decision platform, which is the interface between evidence and decision-making process. This is very clear in the UCS, but very unclear for CSMBS and social health insurance. So we have uneven outcome. Also, national data platform, we work closely with NSO. We are able to monitor, create tool monitoring on an annual basis, monitor unmet healthcare need every 2 years. We have every 3-4 year incident risk factor monitoring and national health account, national aid spending account, and primary healthcare expenditure, and also national health exam survey. All these are evidence for informing policy. What are the emerging challenges? Thailand become older before it become rich. Compared with Japan. Japan spent 24-25 years to emerge from aging society to age society, which is a benchmark of 7% of their population over 65 years from age to aging society. And the benchmark of 21% is the super aging. Thailand spent a shorter duration, only 19 years. And our GDP is much smaller than Japan. So that means in long term, we might not be able to finance the older population who use more services. They have multiple comorbidity, they have NCD, they have disability. Not only health, but social care services also are challenging for Thailand in the light of rapid demographic transition. Very low effective coverage of DM hypertension as measured by A1C, hemoglobin A1C, and effective control of blood pressure, and also high admission of ambulatory sensitive care. You look at 2016 to 19 for the first upper panel for DM and lower panel for hypertension. Only net benefit is 15.7% for hypertension, well controlled, and 11.7% for diabetic. which hemoglobin A1C is under 6%. Most outstanding is CSMBS, which pay outpatient on a fee-for-service with supplier-induced demand. That spending is 4 times per capita higher than UCS and SHI. So this is gross inequity and gross inefficiency in the CSMBS, the green bar between 2022 and 25. So what we are doing? These are the current response, the final slides. We are aware and acknowledge the problem and ready to act based on evidence. We have to estimate resource indication and curb down the low value care. And we foresee strong resistance from pharmacy industry and professional organization to defend their own personal interest, professional interest, and pharmaceutical interests. Identify and manage cost driver, which is fee-for-service in CSMBS outpatient payment and use of non-essential medicine. We are looking at medium term, working closely with ILO, World Bank, and colleagues for protection of CHG and THG as percent GDP, and look at policy control knobs. Slow down the ever expansion of new intervention into the benefit package of UC scheme. I am chairing the subcommittee on benefit package. They are ever increasing new super specialist intervention that might not be affordable in long term. Once you allow into the benefit package, it will never be unlisted. Therefore, must be very careful in the ever expansion of new intervention into the benefit package. Strengthening quality of care, effective coverage, minimize admission of ASC, and also address commercial determinant of NCD through application, WHO based by intervention, taxation, enhanced SBS, sugary sweetening beverage, SSB, sorry, and tobacco and alcohol excise tax. This is the end. Thank you.